Welcome to the Deep Dive, the place where we try to turn dense academic stuff into knowledge you can actually use and remember.
Hopefully.
Today, we're diving deep into some really foundational antimicrobial drugs. We're looking at Chapter 43 from Lilley's Pharmacology.
Yeah, the big ones. Sulfonamides, penicillins, cephalosporins, macrolides, and tetracyclines.
Our goal? Basically, pull out the absolute core stuff, the mechanisms, the risks, the clinical points you just have to know for taking care of patients.
And look, this is really the bedrock for managing infections. Before we even touch on a specific drug class, we've got to get the basic language right.
Right, because messing up the terms, well, that can lead straight to clinical mistakes.
Exactly. Let's start with just the definitions people often muddle up.
Okay, so antibiotic, generally it's a chemical that, kills or messes with an organism's development. But what about cleaning surfaces versus skin?
Ah, good distinction. That brings in antiseptics and disinfectants. Antiseptics are static, they inhibit growth, and you use them on living tissue.
Like prepping skin for an injection.
Right. Disinfectants are cidal, they kill, but they're for non-living things, like countertops. They're usually too harsh for skin. Understanding static versus cidal is key.
And that links directly to how the drugs work.
Right.
The actual drug action.
Precisely. You've got bactericidal drugs, they actively kill the bacteria.
Aggressively kill them off.
Yeah. And then bacteriostatic drugs, which just kind of slow down or stop the bacteria from multiplying, they inhibit growth.
So with bacteriostatic, the patient's own immune system has to step up and clear the infection.
That's the idea. The drug holds them back, the body finishes the job, and which mechanism works often depends on the target bacteria itself.
Ah, okay, like gram-positive versus gram-negative. The text mentions that.
Exactly. Gram-positive bacteria, they have this thick, relatively simple cell wall, easier target, generally speaking.
The gram-negatives are the tricky ones.
They really are. They've got that complex cell wall structure, including an outer membrane. That makes it much harder for a lot of drug molecules to even get inside.
That structure difference, like in figure 43.2 in the book, it's like the first decision point for choosing a drug.
It's a huge factor. Knowing the likely structure helps guide therapy, and we usually think about antibiotic therapy in, well, three main ways.
Okay, what are those?
Well, ideally, we aim for targeted therapy. We get the culture results back, see exactly what the bug is and what kills it, and you use a narrow-spectrum drug. Usually takes 48, maybe 72 hours.
But the patient is often sick right now. You can't always wait 3 days.
Precisely. Which leads to empiric therapy. You make your best guess based on the symptoms and likely pathogens and start a broad-spectrum antibiotic right away.
Okay, but there's a critical rule here, isn't there? Something you absolutely must do first.
Yes. Cannot stress this enough. Get the cultures first. Blood, urine, sputum, whatever's needed. Get those samples before giving the first dose of antibiotic.
Because if you give the drug first, it messes up the culture results.
Completely. You might kill off just enough bacteria or inhibit them so the lab can't grow or identify them properly. You get false negatives or misleading info. Culture first, always.
Got it. And the third type of therapy?
That's prophylactic therapy, using antibiotics to prevent an infection.
Like before certain surgeries?
Exactly. Maybe 60 minutes before incision for specific procedures. Or for patients with, say, prosthetic heart valves who are having dental work done, prevent endocarditis.
Okay, that makes sense. Now let's talk about the challenges. Things like resistance and host factors.
Huge challenges. Let's start with what happens inside the patient's body when we use these drugs. When you wipe out the bad bacteria, you often take out the good normal flora, too.
And that opens the door for
Superinfection. An overgrowth of organisms that weren't susceptible to the antibiotic in the first place.
like yeast infections, thrush.
Yep, Candida is a common one, but the really critical one we worry about is C. difficile, C. diff.
Right, that causes terrible diarrhea.
It can be much worse than terrible. Odorous watery diarrhea, fever, abdominal pain, it's a major complication. If you see those signs in a patient on antibiotics, C. diff should be high on your list.
And that's why things like yogurt or probiotics are sometimes recommended to help the good gut bacteria.
That's the rationale, yeah, trying to support that normal flora.
Okay, so superinfection is one big issue. What about those host factors, what the patient brings to the table?
Right, things about the patient themselves that affect drug choice. Age is a big one. We know certain drugs like tetracyclines, quinolones, sulfonamides are generally avoided in neonates and young kids.
Because of effects on bones, teeth, or risk of things like kernicterus?
Exactly. Allergies are another huge one. Penicillin and sulfa allergies are common and can be serious.
And the text also mentions specific genetic things, like G6PD deficiency.
Yes, absolutely critical to consider. G6PD deficiency is an enzyme issue, more common in certain groups, makes red blood cells fragile. Give someone with G6PD deficiency a sulfonamide, and you could trigger massive red blood cell destruction, hemolysis.
Wow. Okay, that's a major risk. And what about slow acetylation?
That's another genetic variation. Some people just metabolize certain drugs much slower because of differences in their liver enzymes.
So the drug builds up in their system?
Exactly. Leads to higher levels, increased risk of toxicity. You might need to lower the dose for those individuals. You really have to consider the whole patient picture.
Okay, this is great groundwork. Let's dive into the specific drug classes now. Starting with sulfonamides. The classic is SMX-TMP, right? Bactrim or Septra.
That's the main one we use, yeah. Sulfamethoxazole combined with trimethoprim.
And how do these work? Are they cytal or static?
They're primarily bacteriostatic, and their mechanism is quite elegant, actually. They're antimetabolites.
Meaning they interfere with the bacteria's metabolism.
Specifically, they block the bacteria from synthesizing folic acid. They look similar enough to a precursor molecule, Pebe, that they competitively inhibit the enzyme needed to make folate.
And bacteria need folic acid to make DNA and RNA.
Correct. But here's the key clinical point.
Why doesn't it hurt us?
Because we don't synthesize folic acid. We get it from our diet. It's an exogenous nutrient for us. So the drug targets a pathway that exists in bacteria, but not effectively in human cells.
Right.
Pretty clever.
Very clever. And what are they typically used for?
They concentrate really well in the kidneys, so they're great for urinary tract infections, UTIs, also used for community-acquired MRSA and certain opportunistic infections like pneumocystis jirovecii pneumonia, often seen in HIV patients.
Okay. What are the big warnings or side effects we need to watch for?
Well, the big one is allergy, the sulfa allergy. It's quite common and can range from a simple rash to really severe, life-threatening skin reactions like Stevens-Johnson syndrome. These reactions can sometimes be delayed, too.
So you need to be vigilant. Anything else?
Oh, yes. Photosensitivity. This is a big deal with sulfonamides. Patients need serious sun protection hats, long sleeves, high SPF sunscreen. They can get really nasty burns.
Good to know. And interactions. Do they play well with other drugs?
Not always. They can increase the effects of sulfonylureas, the diabetes drugs, leading to hypoglycemia. They can boost phenytoin levels, risking toxicity. And they can significantly increase the anticoagulant effect of warfarin, increasing bleeding risk.
So careful medication history is crucial.
Absolutely. And one more key nursing point. Crystalluria. The drug can crystallize in the urine if the patient gets dehydrated.
Ouch. So fluids are essential.
Mandatory. Need to push fluids, aiming for maybe 2,000 to 3,000 milliliters per day to keep everything flushed through and prevent those crystals from forming.
Okay, sulfonamides covered. Let's shift gears completely to the beta-lactams. This is a huge group, right?
Massive. It includes 4 main subclasses: penicillins, cephalosporins, carbapenems, and monobactams. What they all share is that core chemical structure, the beta-lactam ring.
And that ring is key to how they work.
It is. These drugs are generally bactericidal. They work by messing up the bacterial cell wall synthesis. They bind to specific proteins in the bacterial cell wall called penicillin binding proteins.
And that stops the wall from being built properly.
Right. It weakens the wall, and eventually the bacteria basically rupture or lyse because they can't maintain their structure.
The bacteria are clever.
Ah.
They fought back against this, didn't they, with beta-lactamase?
Exactly. Some bacteria evolved enzymes called beta-lactamase or penicillinases that specifically target and break open that beta-lactam ring.
Which makes the antibiotic useless.
Correct. So we fought back by developing beta-lactamase inhibitors, things like clavulanic acid, tazobactam, sulbactam.
How those work?
You combine the inhibitor with the beta-lactam antibiotic. The inhibitor basically acts as a decoy. It binds to the beta-lactamase enzyme and inactivates it, protecting the actual antibiotic so it can reach the cell wall and do its job.
Like a bodyguard for the antibiotic.
Pretty much, yeah.
Okay, let's break down the beta-lactams, starting with penicillins, the original gangsters of antibiotics.
Yeah. There are different types. You have the natural penicillins like Penicillin G and V, then penicillinase-resistant ones like cloxacillin, designed to withstand those enzymes.
Then iminopenicillins, like amoxicillin.
Right, broader spectrum than the naturals. And finally, the extended spectrum penicillins, often combined with an inhibitor like piperacillin tazobactam, which cover even more, including nasty bugs like Pseudomonas.
Okay, is there a really crucial safety point about penicillin G preparations?
Oh, absolutely critical. The long-acting IM forms penicillin G benzathine and penicillin G procaine are thick, milky suspensions. They are only for deep intramuscular injection. Never, ever give these IV.
Why not? What happens?
They are formulated specifically to be absorbed slowly from the muscle. If given IV, they can cause microemboli, blocking blood vessels in the lungs or brain. It can be fatal. Huge medication error potential there.
Yikes. Okay, noted. What about the allergy issue? People worry about cross-reactivity between penicillins and cephalosporins.
Yeah, that comes up a lot. The actual risk of a true cross-reaction is pretty low. The text suggests maybe 1 to 4%.
So if someone had a mild rash with penicillin, they might still be okay with the cephalosporin.
Generally, yes. The guidance is usually that you only strictly avoid cephalosporins if the patient had a history of a serious, immediate hypersensitivity reaction to penicillin, like anaphylaxis, throat swellings, severe hives. Minor rash doesn't automatically rule them out. Clinical judgment is key.
Okay. Let's move on to the cephalosporins then. They're grouped into generations, right? 5 of them.
Correct. First through fifth generation.
Is there a simple way to think about how their coverage changes through the generations?
Yeah, the general trend, it's not absolute, but a good rule of thumb is that as you go up in generations, the gram-negative coverage tends to increase, while the early generations, like first gen, have better gram-positive coverage.
So first gen good for gram-positives, later gens better for gram-negatives.
Broadly speaking, yes. Third and fourth generations have significant activity against complex gram-negative bacteria.
Any specific cephalosporins worth highlighting?
Well, ceftriaxone is a notable one. It's a third gen that's unique because it crosses the blood-brain barrier reasonably well, so it's used for meningitis. Plus, it has a long half-life, allowing for once-a-day dosing, which is convenient.
Convenient. Any specific warnings for cephalosporins?
The main one mentioned is avoiding alcohol. There's a potential, though maybe less common with newer ones, for a desulfurin-like reaction. Basically, acute alcohol intolerance, flushing, nausea, vomiting if you drink while taking it.
Good patient teaching point.
Okay.
Okay, next, beta-lactam class. Carbapenems. These sound serious.
They are. Carbapenems like imipenem, imipenem, ertapenem, they have the broadest spectrum of antibacterial activity of pretty much any antibiotic class we have.
So they're reserved for the really tough infections.
Absolutely. Complicated, severe, hospital-acquired infections, often involving multiple types of bacteria or resistant organisms. They are kind of the last line of defense in many cases. You don't use them lightly because overuse drives resistance.
The text mentions imipenem is always given with something called cilastatin. Why is that?
Ah, yeah, that's a neat pharmacological trick. Imipenem itself gets broken down really quickly by an enzyme in the kidneys called dehydropeptidase. Cilastatin specifically inhibits that enzyme.
So cilastatin protects the imipenem.
Exactly. It allows imipenem to stick around long enough and reach high enough concentrations to be effective. It's purely a pharmacokinetic enhancer.
Interesting. Any major side effects with carbapenems?
The most concerning one is the potential for drug-induced seizure activity. The risk seems highest with imipenem cilastatin, especially at higher doses or if infused too rapidly.
So infusion time matters.
Definitely. Standard practice is to infuse them slowly, usually over 60 minutes, to minimize that risk.
Okay. And the last beta-lactam class is monobactams, like Astrium.
Yeah, Astrium is the main one. It's structurally a bit different. Its main niche use, often, is the inhaled aerosolized form.
Inhaled. For what?
It's used specifically for managing chronic lung infections caused by Pseudomonas aeruginosa, particularly in patients with cystic fibrosis. Direct delivery to the site of infection.
Fascinating. Okay, we've covered cell wall inhibitors. Let's switch mechanisms entirely now. Protein synthesis inhibitors. Macrolides and tetracyclines.
Right. Different targets altogether. Let's start with macrolides, erythromycin, azithromycin, clarithromycin.
How do these work?
They are primarily bacteriostatic. They bind to the 50S subunit of the bacterial ribosome, basically jamming up the machinery that makes proteins. No protein synthesis, no growth.
Erythromycin, isn't that one known for causing stomach upset?
Oh, yeah. Significant GI side effects, nausea, vomiting, diarrhea, are very common with erythromycin. But interesting,
that side effect actually became useful.
Exactly. It irritates the GI tract so much that it actually stimulates motility. So now, erythromycin is sometimes used off-label, specifically for that effect, to help patients with conditions like diabetic gastroparesis, where the stomach emptying is delayed.
Turning a bug into a feature.
Pretty much. Now, azithromycin and clarithromycin tend to be better tolerated GI-wise.
But macrolides have other potential issues, right? Cardiac risks.
Yes, that's a significant concern. They can prolong the QT interval on an ECG, which increases the risk of potentially fatal heart rhythm problems, like torsades de pointe. This risk is higher if they're taken with other drugs that also prolong the QT interval.
And what about drug interactions?
Big issue here, especially with erythromycin and clarithromycin. They are highly protein-bound, and they inhibit cytochrome P450 enzymes in the liver.
Ah, the P450 system. That affects lots of other drugs.
Loads of them. So macrolides can increase the levels and toxicity risk of drugs like warfarin, theophylline, certain statins. The list is long. You have to check for interactions carefully.
Does azithromycin do that too?
Less so. That's one advantage of azithromycin, Zithromax. It has fewer significant P450 interactions compared to the other two.
Good to know. Okay, let's move to the other protein synthesis inhibitors. Tetracyclines, doxycycline, tigecycline.
Right. These are also generally bacteriostatic, but they target a different part of the ribosome, the 30S subunit. They also block protein synthesis.
What's the big defining issue with tetracyclines? Something about binding.
Chelation, that's the word. They have a very strong affinity for binding with metallic ions, things like calcium, magnesium, aluminum, and iron.
Like in milk, antacids, iron supplements.
Exactly. If you take tetracycline with those things, the drug binds to the ions in the gut, forms an insoluble complex, and just doesn't get absorbed. It makes the drug ineffective.
And this binding is also why they're a big no-no in certain populations.
Absolutely. That binding to calcium is the problem. They get incorporated into developing bones and teeth.
So contraindicated in.
Pregnant women, breastfeeding women, and children under 8 years old. It can cause permanent staining, yellow graying of the teeth, and potentially affect skeletal development. It's a strict contraindication.
Wow. Permanent tooth discoloration. Anything else major?
Like the sulfonamides, they cause significant photosensitivity. Serious sun avoidance is needed. No tanning beds.
Okay. And there's a newer one, tigecycline.
Yes, it's technically a glycylcycline, but related. It's effective against some really tough resistant bugs, including MRSA and VRE.
Doesn't catch.
A big one. It carrying a black box warning from health authorities about an increased risk of death from all causes compared to other antibiotics used for similar infections.
Increased all-cause mortality. That's serious.
Very. It's generally reserved for situations where other options are limited due to resistance patterns. It's not a first-line choice.
Okay, we've covered a lot of ground on mechanisms and risks. Let's try to pull this together with some key nursing considerations and patient teaching points. What do we really need to focus on?
Well, across the board, monitoring for superinfection is crucial. Keep checking the mouth for white patches thrush, ask about vaginal itching or discharge yeast infection, and always be alert for that C. diff diarrhea.
And reminding patients about probiotics might help.
Can't hurt, might help.
Yeah.
Encourage yogurt, kefir, things like that.
What about specific administration advice? You mentioned chelation with tetracyclines.
Right. For tetracyclines, take them with a full glass of water, like 240 milliml, to help prevent esophageal irritation. And critically, separate the dose from dairy, antacids, iron supplements by at least 2, preferably 3 hours. Don't take them together.
Okay. What about penicillins?
Take most penicillins with water, not juice, as acidity can decrease effectiveness. And check specific instructions. Some, like penicillin V or cloxacillin, are best absorbed on an empty stomach. That means 1 hour before food or 2 hours after.
And sulfonamides.
Those are usually recommended to be taken with food to minimize GI upset, and always with that large amount of water we talked about to prevent crystalluria.
Okay, one last really important teaching point, especially for women of childbearing age.
Ah, yes. Oral contraceptives. Several of these antibiotic classes, specifically penicillins, macrolides, and tetracyclines, can potentially reduce the effectiveness of birth control pills.
So backup contraception is needed.
Absolutely. Advise patients to use a reliable backup method, like condoms, during the antibiotic course, and usually for about a week after finishing, just to be safe. It's a critical piece of counseling.
Definitely. So, wrapping up, we see the difference between killing bacteria outright, like the beta-lactams do by hitting the cell wall,
Right, the bactericidal action.
versus just inhibiting them, like the macrolides, tetracyclines, and sulfonamides do by targeting protein synthesis or metabolism, mostly bacteriostatic.
And we've hit those key clinical limitations, things like the chelation issue with tetracyclines, the P450 interactions with macrolides, the allergy potential with penicillins and sulfa drugs, the need for fluids with sulfonamides.
It's a lot to track, but crucial for safety. Okay, that brings us to our final thought for you, the listener, to chew on. We know antibiotic resistance is driven by overuse. Now that you have a better handle on how these drugs work, their side effects, and their specific targets. Think about this. When you're faced with a patient, maybe they have a cough and some colored sputum, or just feel generally unwell. What specific things, beyond just checking boxes, do you really need to assess in their history and presentation to decide if an antibiotic is truly necessary?
How do you avoid contributing to the problem when maybe it's just a virus or something else entirely? That diagnostic skill, knowing when not to prescribe.
That's maybe the most important skill of all for antibiotic stewardship.
Couldn't agree more.
Well, this has been a really productive deep dive into these essential antibiotic classes. Thanks so much for walking us through it.
My pleasure. It's vital information.
And thank you all for joining us. We will catch you on the next Deep Dive.